American hospitals have been living with serious drug shortages for more than a decade. Most days, nearly 300 essential drugs can be in short supply. After months of investigation, we found it's not a matter of supply and demand. The drugs are needed and the ingredients are easy to make. It's that pharmaceutical companies have stopped producing many life-saving generic drugs because they make too little profit. Yet year after year, the government stays on the sidelines as companies take drug production offline and doctors worry the shortages are compromising patient care.
The story will continue in a moment.
Just normal things that should be available, but they're not.
Neonatologist Dr. Mitch Goldstein treats the most vulnerable patients at Loma Linda University Children's Hospital in California.
Most of these babies would fit comfortably in the palm of your hand.
Struggling to hold on to life.
They really are.
Many of these premature and sick babies have undeveloped digestive systems, so Dr. Goldstein keeps them alive with intravenous nutrients, many of which are in short supply.
It can be certain minerals, it can be certain salts, things that you would ordinarily find in a college chemistry lab, we can't get.
But these are basic.
These are basic things. Glucose, sugar, it's not hard to make. But the point is, we can't get it.
So then what are your options?
You don't have any. You do the best you can.
And then if it's something that's an IV that needs to be compounded.
Anthony Gobin heads the pharmacy at Loma Linda Hospital. He told us shortages of basic drugs are a constant worry.
Help me understand, how often do you face drug shortages?
Every day.
Is this just another casualty of COVID?
No. So we were dealing with shortages long before COVID. They're all very old, fundamental drugs that every hospital in the country needs and uses.
Drug shortages can kill. In 2011, when norepinephrine, an old, low-profit drug used to treat septic shock, was in short supply, hundreds of people around the country died.
Yeah, that one's also still in back order. We can't get it.
Just about every hospital in the U.S. has weekly drug shortage meetings like this one at Loma Linda.
It's like dextrose.
Dextrose vials, still completely out of the vials. We're using these syringes for everything.
During a drug shortage, hospitals may be forced to switch patients to less safe or effective alternative drugs. They retrieve leftovers from single-dose drug vials to share with other patients and avoid wasting a single drop.
That's the pharmacist, maybe further concentrating to try to conserve some of these 100 ml bags. You would think to yourself, how hard is it to manufacture some of these simple meds like dextrose or sterile water? But some of these are low-margin drugs, and then because of that smaller margin, you don't have a ton of manufacturers making the product.
Sarah Carney and Cindy Valenta were facing the same wrenching ordeal at Loma Linda Hospital. Both had children undergoing chemotherapy for aggressive leukemia.
Just so many different chemos.
Sarah's son Micah was in pre-kindergarten when he began the painful treatment.
He wasn't the same kid. Several times he looked at us and said, "Why is this happening to me? What did I do wrong?"
So much is being thrown at you. New back then, I didn't understand. I thought there was one type of chemo that people took when they had cancer. I didn't realize there was this whole roadmap, this regimen we had to follow.
They give you a schedule and they tell you you must stick to that schedule.
Every function of your life went on this roadmap. So if chemo was supposed to be given on day 1 and day 5, whether that was a holiday or not, we had to take John in to get his infusions.
Cindy's 13-year-old son John gave up baseball to beat his leukemia. In late 2019, he settled into his usual chemo chair and got some bad news. The chemo drug vincristine he'd been using for more than 2 years was suddenly unavailable.
This was after the doctors had insisted with you that you keep to this schedule. What was John's reaction?
Scared.
Vincristine, an essential drug for childhood leukemia, was in short supply nationwide. It's a chief ingredient of a chemo cocktail that has an 80 to 90% cure rate. When Sarah learned Micah wouldn't get his treatment, she was on the phone for days, calling anyone who might know how to get the life-saving drug. Other cancer moms, the hospital, Pfizer, the drug maker.
I honestly didn't even know who to believe because the pharmaceutical company is telling me they have it. And the hospital is telling me we call them every day. And they're telling us they don't have it. So I didn't know what to say.
As a cancer mom, we shouldn't be fighting for our children to get a drug that is needed. You know, we are fighting every day to keep their spirits up, to change our whole life to make sure that they're getting this treatment. There's no other alternative. That's just a gut-wrenching feeling of just fear and anger.
Sarah and Cindy raised all kinds of alarms on social media. A week later, drug maker Pfizer shipped scarce doses of Vincristin to Loma Linda, enough for Micah and John to continue their treatments.
Hi, how are you?
Milwaukee pediatric oncologist Cindy Schwartz is a committee chair of the Children's Oncology Group.
It stings, yeah.
A consortium of cancer researchers and bioethicists from across the country.
These recent shortages have become very, very serious and really hit drugs like Vincristin that are in every regimen.
Slipping it through.
Vincristin was one of 16 chemo drugs in short supply last year. Dr. Schwartz told us the shortages are forcing doctors to ration scarce drugs.
Does that present you with some ethical dilemmas?
Of course it does. Who wants to be picking how you prioritize one person over another?
One child over another.
One child over another.
I'm just trying to come up with some explanation for why a drug that is known to save lives is not valued. Why
it should be a top value.
Unlike newer brand name drugs that cost as much as 6 figures per dose, Vincristin, a low-margin generic drug around since the 1960s, costs about $5 per dose. Months before the shortage, one of the 2 remaining Vincristin manufacturers, Teva Pharmaceuticals, announced it would stop making Vincristin for U.S. hospitals.
They indicated that it was a business decision. They could make more money on more profitable drugs than Vincristin.
Ross Day is a former director of Vizient, the country's largest group purchasing organization, or GPO, a health services company that negotiates contracts between hospitals, drug makers, and medical suppliers.
I don't understand why companies in good conscience can make those kinds of decisions. None of these companies are poor companies. They have the opportunity to not make as much on one drug and still make plenty of margin and profit on other drugs.
Well, those kinds of economic decisions made, not because that person running that business is malicious in their intent, and they are trying to keep that plant operating.
We also met with Bill Simmons, a former high-ranking generic drug executive.
You have to keep in mind that corporations aren't charities.
So how does this work?
The 2 former executives once negotiated drug contracts across the table from one another. They still have disagreements.
You got the generic drug manufacturers.
We asked them to spell out the economics of generic drug shortages, from the manufacturers on the left here,
Distributor or wholesaler.
to the hospitals and patients on the right.
And then you got the patient over here.
We were hoping a diagram would help.
There's a gatekeeper here. I'm putting GPO in. It's called a group purchasing organization. And that organization negotiates prices for the hospital collectively in an effort to get lower pricing on products.
At least that's the way it's supposed to work.
And you got money going this way, they pay it, and then they sell it to the hospital, and then it comes back this way.
The contract price,
This concept of fee for service.
a cost minus.
Why is all of that part of the process?
The honest answer to that is this private label fee for service cost minus, these are things to create lack of transparency to pricing.
But this confusion is on purpose?
Yeah, I want to charge different prices and not have clarity around what people are really paying.
So far, this is clear as mud.
But I'm not sure there are more efficient ways to administer this supply chain. At least I've not been presented one.
There's nothing more efficient than this?
But all the arrows and acronyms point to one thing: a broken system, which our investigation found is a root cause of drug shortages. Take the $5 cancer drug vincristine. The middlemen, the group purchasing organizations and drug distributors, take their cut for administrative, marketing, and other fees and hospital incentives. The drug manufacturers end up with just a small fraction of what the patient pays. Many have simply stopped making the least profitable drugs.
We are systematically shutting down all of our U.S. manufacturing because we do not pay enough money for the drugs to the manufacturers. And not enough money is paid because of the middlemen.
I guarantee you that the patients over here would say, I would pay more if I could be guaranteed I would get these drugs when I need them.
Bill, I think this person over here might be willing to pay another $20, but these people will absorb a lot of that $20 before it gets over here.
Group purchasing organizations control more than $250 billion in hospital purchases annually. The biggest three account for about 90% of the business. They typically award the contract to the manufacturer with the lowest priced drug. Add in all the complex fees, and the group purchasing organizations grow wealthier, while losing manufacturers are squeezed out.
If you refuse to sell through group purchasing organization or through drug wholesalers, you will not exist.
You're out.
You are out.
It's not in the GPO's best interest at all to drive anybody out of the market. I've attributed more of the drug shortage problem to some decisions by FDA to start evaluating manufacturers differently than they had in the past.
The FDA, to improve patient safety, raised the bar on quality controls at drug plants. Several were shut down.
The FDA wants higher quality products that cost more money to make, and the GPOs want to drive the price down to whoever will supply them the lowest price, which is usually people who are not investing in equipment, not investing in quality. And those two things don't go together.
In July 2019, when Teva Pharmaceuticals stopped making vincristine for lack of profit, Pfizer's generic division, Hospira, became the sole supplier. In a letter to the FDA we obtained, Pfizer called the situation untenable. 2 months later, a quality control issue forced Pfizer to suspend production for 6 weeks, which is not uncommon in drug manufacturing.
When you're down to just a couple of manufacturers and one is found to have quality control problems, where do you go? There's no plan B.
There is no plan B.
40% of generic drugs now have just one manufacturer.
I think the government could play a role in keeping some of these drug manufacturers viable, because this is just as much of an emergency in my mind as the pandemic is, but I'm not ready to say the current model is ready to blow up. Maybe tweak.
Back at Loma Linda,
I think about the babies I take care of.
Dr. Mitch Goldstein, like doctors all across the country, is bracing for more shortages.
It's horrible, and it's like being in a siege and you're running out of ammunition. Sometimes we look at it and it's just, how are we going to survive this next day, the day after? And what is the new problem? What's on the horizon? What's going to happen next week?